Okay, this lecture is about the gastrointestinal products. It's poop. Okay, so we're going to go through this pretty basic lecture. So what is stool? Stool consists of undigested food, epithelial cells that have been sloughed off, mostly intestinal bacteria, as well as various GI secretions, some bile pigments, a little bit of electrolytes, and some water. Okay, normally you should produce about 100 to 200 milliliters, not that many stools, but grams, exactly, grams of stool per day. Every 18 to 24 hours, the small intestine turns over, the contents of the small intestine turn over through excretion. So if it takes longer than that, that's pretty slow peristalsis that's or it is slow peristalsis that's allowing it. So that's one of the reasons why we say that a stool that's collected in the morning is the same as a stool that's collected in the evening. You have to wait. It should be a full day, but we at least 18 to 24 hours between specimens. Okay. Now the large intestine can absorb up to 2,700 milliliters of liquid. And the large intestine, primarily, that's its job, is to reabsorb liquid. If there's an increased amount of reabsorption, you're going to end up with constipation. If there's a decreased amount of reabsorption, diarrhea. Okay, now that can be because there's less fluid entering the large intestine, and so that 2,700 milliliters is absorption, but the relative percentage is increased of fluid is increased. Same thing with diarrhea. More liquid can be entering the large intestine, so 2,700 milliliters isn't going to be enough, and you end up with diarrhea. One of the things that we do have to also be on the lookout for with stool specimens that we get is the condition called steatorrhea. In steatorrhea, the percentage of fat in the stool has been increased. Normally you should have less than 7 grams in your stool per day, not per specimen, per day. Okay, so steatorrhea is something that's done, and that's averaged because again it's 18 to 24 hours. When we want to test for the presence of fat in the stool, if you want to remember, I've always said nothing good ever comes in a brown paper bag. Nothing good ever comes in a paint can either. The specimen for stool fat analysis is a 72-hour stool collection, and it's collected literally in, well, it's a paint can. That's what it looks like, and it comes in. Don't open that. Don't open that. You want to let the person who's doing that test do that. So why would you have steatorrhea? Well, they're associated with malabsorption syndromes. And the stool that has that increased fat in it is very, very stinky, very, very foul smell. It'll be usually pale and greasy looking, like a spongy, pasty, gross looking. But the biggest thing is the smell. The smell is just awful. And so you can see here in the little picture, they're saying on average, 9,000 milliliters of fluid enters the GI tract each day. That's at the top of the small intestine. The large intestine, only between half and 1.5 liters enter the large intestine, with about 150 milliliters being produced in normal feces a day. Now, when we receive stool, it's usually not because people felt like giving us a stool. We're usually trying to identify the cause of a problem. Obviously, if a person is constipated, we already know that because they can't produce a stool, so that's not on this list. When they have diarrhea, however, we need to figure out what kind of diarrhea they have. Do they have secretory diarrhea, where you have so many extra solutes being secreted by the intestine for a variety of reasons that'll increase the total fluid volume that ends up going into the large intestine? The large intestine will still reabsorb its 2,700 milliliters of fluid, but if you have more fluid entering, you can't you can't compensate for that increased volume. Okay, if it's osmotic diarrhea, the solutes that are in the gut are actually more osmotically active, and so that causes an increase of secretion of water and electrolytes, and so that large amount of fluid is unable to be reabsorbed in the large intestine. And then the third reason is for intestinal hypomotility. And this is where, remember, peristalsis is normally pretty slow, but if peristalsis increases, the speed of it increases, then the amount of time that the material remains in the lumen of the gut, there's not enough for absorption and reabsorption of water to occur. Okay, so the causes, they're listed there. You can read through them. Secretory diarrhea frequently involves your infections, okay? You know, whether it's the bacteria that produce an enterotoxin, which affects the mucosa, viruses that cause gastroenteritis. Some drugs can cause diarrhea. I'm sure you've heard in the side effects of various drugs, explosive diarrhea. That's a bad thing, but some drugs can do that. Some drugs, legal drugs, caffeine, certain steroids and things like that can also cause diarrhea. And then neoplasms are known to be a problem. Osmotic diarrhea is usually a little bit different. Usually it's not a bacterial or a viral problem with osmotic diarrhea. It could be something as far as if you have these extra solutes in there, maybe it's a question of maldigestion or malabsorption. Also, if you've caused a change in your malabsorption or maldigestion, so antacids and things like that, which can change how your gut works, okay? There are also certain parasitic infections that can cause osmotic diarrhea because they're producing waste products that will increase the that are full of osmotically active solutes. And then, of course, if you've had small bowel resection where you can't reabsorb these materials and they end up entering the large intestine, reabsorption of water will be affected. The intestinal hypermotility, and that should say intestinal hypermotility, this is usually, it can be a symptom of either secretory or osmotic diarrhea. So various infections and various issues can cause hypermotility. But there are also other things, you know, some of the drugs that we take, some of the laxatives that we take cause this to help get rid of these, of the stool that's in the gut, as well as some stress, some other drug, parasympathetic nerve issues, so stress, that's where the stress comes in, and certain other, it's a byproduct of certain other drugs. In order to figure out the difference between either diarrhea or steatorrhea, so is this just regular diarrhea or does it have fat in it? Look at the characteristics of the stool that you get. Diarrhea is just going to be watery and loose. I mean, it can have some strange colors, red, black, things like that, but it shouldn't be stinky, greasy. Well, all stool is stinky, but really, really foul odor. That's the key thing that you look for. And when you do that, you do a fecal fat determination. If it is present, you still need to figure out why that's there. You still have a place to go. But if it's absent, there are still a couple other steps that you need to take. You have to eliminate the role of the liver or the pancreas in the production of this greasy, foul stool. If it's just a watery or a loose stool, we're going to look for a couple of other things. We can do fecal WBCs to help determine if we have an infectious cause. Okay. If there are no WBCs, likely it's probably a parasitic or a virus infection. If, however, there are fecal WBCs, one of the things we have to consider is the stool culture because it's likely bacterial. We can also do a fecal osmolality, which will help us determine is this secretory diarrhea or osmotic diarrhea. These are tests that so the tests that you're going to do are fecal WBCs, fecal osmolality, and fecal fat determination based on the characteristics of the stool that is produced by the patient. Specimen collection obviously is done by the patient, okay, and it's not something that's necessarily done on command. Obviously, the patient has to take home a kit, has to be instructed on how to use it. We give the patient a commercial collection kit, and you can see how it spans the toilet so that you can collect the stool. But if the patient is at home and is unable to come in and get that, saran wrap works pretty fine as well and has been used for ages without these fancy commercial kits. You just stress the saran wrap across the toilet, not across the whole thing, because then you could have a mess, but you make like a strip just about that width. So you'd have saran wrap maybe from here and here, and loose saran wrap so that it'll act in the same way. The containers that the stool should be collected in should be a sterile container. You want to avoid contamination. The stool itself is not sterile, but you want to avoid adding anything extra to it, and not just bacteria, but the key thing is you don't want to add anything from any other part of your body to it, urine being the key thing. And the amount that you're going to need is really based on but we usually don't need that much, based on the test that's going to be performed. And remember, since each specimen is, each day you produce more than one specimen that really is the same, we require multiple day collections. There's so much stuff in there that we usually want to look at 3 specimens to get a representation of what's going on in the patient. So, and the exception to that would be the fecal fat, where we take everything you produce for 3 days. Now, microscopic exam for stool can include a few different things. The 3 most common would be fecal leukocytes. That's very commonly done. We want to look for the presence of white blood cells in the stool. Even a few white blood cells. There should be none. Okay, so this can be done with a red stain. It can be done with methylene blue. We used to do it with a gram stain. You can do it a lot of different ways. It does not require that you do a differential, although I did work for a hospital where we had to do a diff, which was really fun, let me tell you. But we did it with a gram stain. And that's because, why did we do it in microbiology? Because hematology hates poop, that's why. They didn't want it in their stainer, so we used to do it. And you could see to be able to differentiate if it has a infectious, a bacterial cause, it's likely that you're going to see white blood cells present. Okay, and absent. Also, fecal leukocytes are also a test that could signify the presence of some kind of neoplasm. The other stain that's done would be the fecal fat, and you've heard of these stains before with the Sudan red 3 or 4 and the oil red O. In this case, to do a fecal fat test, pretty simple. You take a slide that contains the specimen, put a couple of drops of 95% ethanol plus your stool on that slide, and then you add the stain, whichever one you choose, and you cover slip it. So it's a wet mount kind of slide. And you look for the red or orange discoloration that you would see that would occur with the fat. Now, a certain amount of fat, a small amount of fat is fine, okay? And what we look for on high power is less than 60 globules of fat per high power field. So these are just neutral fats that are being stained. So you look for the total number. And then on a second slide, you actually acidify the stool with acetic acid, and you heat the slide, which, let me tell you, smells wonderful. And then you estimate that slide, and so it's again, you add the stain and cover slip it. And then what you're doing here is the acidification is going to hydrolyze any fatty acid salts that are present. It's going to hydrolyze them into their the, into their respective fatty acids, and the heating will cause the fatty acids to absorb the stain. So you'll be able to see more fat using the second slide. In that case, you want to see less than 100 globules, so you have a slightly higher bar to reach, okay? And the globules shouldn't exceed more than 4 millimeters in diameter, so you have to measure them. So you can see this has globules, but they're small, whereas this one you have some pretty large globules present, and this one would be considered positive. Then the third thing that we're going to stain for is the occult blood, and it's actually done with a simple test, a little card test. This is an example of I'm sorry, this is not, no, it does look like the guaiac test. So the guaiac, or the occult blood, so named for the reagents that used to be in it, is a card test, and the collecting person gives it hopefully to the nurse, who will smear stool on one side of the card. So this actually looks like the side that the stool is smeared on, but it's hard to tell. And then reagent is added. And if you look on this one, you can just see the stool, the brown, the yucky discoloration. But on this one, you see this blue coloring on the outside. This is after the addition of the reagent, of the guaiac reagent, and that blue color means that there is blood in that specimen. Now, blood shouldn't be in the stool specimen, but just because you have blood in the stool doesn't necessarily mean that you have a bleed or anything like that. Blood in the stool is one of the screening tests that we use for colon cancer, but it's very, very early and very, very insensitive. If you had steak for dinner, if you have had aspirin or anything like that, can cause a false positive fecal blood test. Some of the other tests that we do, and I mentioned it, it was on one of the earlier slides, pancreatic insufficiency. Pancreatic insufficiency, where basically you're looking for maldigestion here. The pancreas is not producing the enzymes that it needs to produce in order to process the food that you're eating. Okay, probably the most common test that's done is the D-xylose adsorption test. And the D-xylose adsorption test will help differentiate pancreatic insufficiency from malabsorption. So where there's something wrong with the lining of your stomach. Basically, what you test for is you give the patient xylose, and xylose will be processed and absorbed by the small intestine without the need of any pancreatic enzymes. It's not going to be metabolized, and it'll be excreted into the urine. So we actually can do these tests by giving the patient xylose and look at the urine levels to see if xylose is secreted into the urine. If you don't get any into the urine, it's not being absorbed by the small intestine. Okay. And then we also have a test called the fecal elastase test. And this is a test that allows us to detect, usually it's found in chronic pancreatitis. That's what it's most sensitive for. So the test that we have here, you can see, you have the secretin stimulation test, where we inject through the intravenously secretin, which causes the aspiration of pancreatic juice into the duodenum. And then we can take bicarb and amylase levels. And low levels of those are consistent with pancreatic insufficiency. The fecal chymotrypsin level is, if you have a low chymotrypsin level, that's associated, because that's a product of the pancreas, of pancreatic insufficiency. The elastase test we already talked about, if it would be low, you just test the fecal specimen for an elastase level. It's an enzyme produced by the pancreas. And then serum trypsinogen level, this is a separate test not done on stool. So, but the fecal levels, chymotrypsin and elastase, we're testing specifically the stool itself. The D-xylose, we can test the urine. Okay. see if we give you a known dose of D-xylose and test your urine and see how much you are able to absorb. In some cases, we also test the gastric contents, which is meaning the contents of the stomach as opposed to the contents of the intestine. It's not very common, but sometimes we do have to. And what happens is with some patients, they produce what a tumor in a particular syndrome called Zollinger-Ellison syndrome. The patient produces a gastrin-secreting tumor. The gastrin then stimulates the wall of the stomach to produce hydrochloric acid. So this is a gastrinoma. It's usually originating in the pancreas, but we can see its effects in the stomach. And so the patient's going to, with all that extra acid, the patient's going to experience some ulcers, not just in the stomach, but also in the duodenum, which they can be quite painful. So if we can get a gastric contents sample, we can just do a hydrochloric level, and if we have excessive hydrochloric acid levels, that's definitely indicative of a gastrin secreting tumor. Even easier than trying to get the gastric contents, we can do a plasma gastrin level. It actually works out pretty well. Very high levels of plasma gastrin are usually diagnostic of Zollinger-Ellison syndrome, and the very high level would be anything over 1,000 picograms per milliliter. I mean, if you wanted to do the gastric pH, which would be decreased with excessive HCl, you would titrate the gastric contents with 1 normal sodium hydroxide to a pH of 3.5 to get a free HCl level. And then for total acidity, you'd continue titrating to a pH of 7.0 to get those levels. And if you have a very high level of HCl or low pH, that'd be a pretty good sign that you have some kind of increase in HCl production, which might be related to Zollinger-Ellison syndrome. And then we do also have these fun guys here. These are parasites that can be found in the gut or meaning in the stomach, but usually more often in the intestine. And they include, they're a fun bunch, tapeworms, nematodes. There are protozoa as well, flukes, hookworms, and roundworms. Okay, they all start off in the intestine. All right. As a general rule, they hopefully will be self-limiting, especially in the United States, the ones that we find here. But every once in a while, people get a really good one, and you'll go through these when you take parasitology.